I'd like to congratulate you on your success with the RCA.
Oh, thank you. It's really kind of you. And thank you very much for having me on your RCA Blueprint course.
Welcome to RCA in Focus. In this series, we dissect the mindset, strategies, tactics, and tools to help you crack the RCA. In today's episode, I'm joined by Dr. Carolyn Asher, who recently passed the MRCGP RCA first attempt. This is a video you want to watch until the end if you're preparing for the RCA, because we're going to dissect Dr. Carolyn Asher's preparation. We're going to talk about her approach to the RCA, how she actually adapted her consultation method, how she improved her data gathering to compress it within 6 minutes, to transition to clinical management. What did she do to actually score well in clinical management by formulating a shared management plan involving the patient, safety netting, and follow-up. Caroline is going to share her insights as to how she marked her cases, how she selected her cases for submission, and what she wished she did earlier in her preparation. I suggest you get yourself a pen and notepad and make some notes from this episode because you're going to learn a lot and I'm sure it's going to help you in your preparation.
So Caroline, would you like to introduce yourself?
Oh, hello, Owen, and thanks very much for having me. I really appreciated when I attended your RCA Blueprint course sometime before I took the exam, and it's really nice to see you again. And thank you for helping me to pass. I used to be a consultant psychiatrist, and I'm really, really grateful that I got the opportunity to retrain as a GP. That was something that I think I should have done a long time ago, but sometimes you start doing a training and it's like being on a train. You just carry on in that field. But I'm very glad to have made that career change, and obviously it's essential to pass your exams, isn't it? So in some ways that's very different to, I haven't come across anybody else that said they were a consultant psychiatrist and now they're retraining as a GP, but I think a lot of people have done something else before they start on the GP training. So hopefully, some of my experience might help somebody else.
Absolutely. And we'll talk about the case selection that brings your psychiatric experience in it later. So let's talk about how did you prepare for the exam? What was your mindset when you first started preparing with this exam in terms of, because you have to change the way you consult in general practice, and coming from a psychiatric background is different.
Yes, definitely. I think one of the really important things to think about with the RCA is to see it as preparing you for your future job. Because if you are going to be working independently, chances are you're going to have 10-minute appointments. And if you like, this is an opportunity to hone your skills so that you're going to be able to survive in that environment. And I think also you have to think of it as that the college had to put this exam together at speed so that everybody could, complete their training and, get their registration with the GMC. So it's what they could put together for us based on the CSA, and in the more distant past, people used to send in videos. So it's worth just sort of thinking it's not designed to sort of trip you up or persecute you. Just try and make the best of it as an opportunity, but also try and figure out, what's your strategy going to be? Really assess what you're about, what are your strengths and weaknesses. So I think a lot of registrars would probably be in, to some degree, the same situation as me, in that one of the really important things is to make sure you've got enough clinical management knowledge. If you haven't, you definitely don't pass the RCA. It's not about style, it's mainly about substance, and lots of different styles are tolerated anyway.
That's a very good point you make, Caroline. There are many ways of skinning a cat, but essentially we're all doing the same thing, that we want to consult and manage our patient. So tell us how you actually develop your consultation in terms of the structure that you use.
Yeah, so when I started out, I was taking an inordinately long time to do a consultation. And part of that really was because I was having to really think and remember and think like, oh, what are the red flags, or or, you know, what do I need to ask about for this set of symptoms? You can lose a lot of time doing that. So the more you can study around the clinical management side of things, the more you can sharpen that up so that you're more efficient. And then I more or less followed the style that they recommend on FourteenFish. So the FourteenFish RCA package is, I think, completely essential for trainees to subscribe to. And the lead behind that was one of the people that developed the RCA exam itself. On the other hand, they do explain, like you said, more than one way to do this. Other styles would be tolerated, but this is what sort of worked for me. And what I would tend to do, I would tend to have this written down on a piece of paper before I start making the phone call for, you know, a consultation that I'm hoping to record. I'd literally have these headlines written down, and then I'm writing my notes, just brief notes, on that same pad of paper. So I'm not going to forget something. And also, if there are little bits of information that I want to remind myself before I make the phone call, like say if it's a particular disorder that the patient probably has, and I might forget a red flag, that maybe I've had that habit before of forgetting a red flag, I can just jot it down on my piece of paper before I start the phone call to make sure I definitely don't forget that particular red flag. So it's literally, you know, confirming their name, their date of birth, is now a good time to speak to you. And you have to have a real sort of warm, welcoming voice, especially with it being a phone call, and you know, they know they're being recorded. You've really got to win them over in the first, you know, few seconds. Your voice has got to smile. If you have a smile on your face, that helps. And then I literally write on my pad, open question, because if you try and be too formulaic about how you do those open questions, then you might trip yourself up. But something like, how can I help you today? Sometimes if the patient has already said something, and it's, you know, maybe they've typed in what the problem is, they might not appreciate it if you just completely say, how can I help you today? Some people will take offense if they've taken the trouble to either, you know, tell the receptionist or type it in themselves. So sometimes people differ on this. Some people say, oh, you know, you've just got to be a completely open question, how can I help you today? But I've had quite a few patients take umbrage. So I might say, you know, oh, you know, I understand that you've contacted us and said that you were having trouble with your periods, for instance. But then after that, you know, keep it really open, like, you know, can you tell me a bit more about what's been troubling you with your periods? And then I will mention hopefully later about some tips that Roger Neighbour says that help with this structure as well. But you, according to Roger Neighbour, you're really trying to keep the first bit as the patient's part. So the less you can interrupt, and if you do interrupt, it's really just to get them saying their story a bit more, the better. And you're trying not to medicalize at this point. And then, like in FourteenFish, they suggest that you try and get the psychosocial in really early, and that often does work. On the other hand, if the best thing you can be doing is really listening to the patient and really sort of asking things that are going to bring out more of their story at the minute. So if it would sound awkward, then obviously don't do it. But if it flows, then you want to know about them and their lives, what their job is, how is life at home, you know, how are these problems affecting you in your life at the minute? Is there anything it's stopping you from doing? So that's the psychosocial. And as I say, I'll be jotting down their answers. And then the ICE, instead of writing ICE on my sheet, I write thoughts, preferences, or what do they prefer to do, and worries, and then obviously red flags, and any other questions that clarify what the diagnosis is. And like you've said on your course very helpfully, you've really got to develop a sense of knowing when to stop with those sorts of questions, because we're into the doctor's bit now, trying to find out things what you want as the doctor, because now you are trying to decipher, is this an illness or is it symptoms that don't actually amount to any illness, or you know, indeed, are there any red flags that you've forgotten? But like you said in your course, you're not chasing perfection. You're not there to ask every symptom in the textbook about that disorder. You just got to do enough and then stop. And then you've got to come up with the diagnosis then. And anything that you want the examiner to give you a mark on, you've got to make sure you've said it out loud. If it's just in your head, you're not going to get any marks for it. So you want to say what you think is going on and explain a little bit what that means. And then you've got to agree a management plan. I've heard that explained in different ways, but what I've found helpful, like say for instance it was depression, you might say, oh, you know, some people more prefer like a talking therapy and some people more prefer medication, or other people would say they'd be interested in both. So you could say something a bit speculative like that and see how they react to it, and then go in the direction that they are taking you in, and offer them, you know, what the treatment could be. And you have to make sure if it's a medication, you have to say the actual name of it and the dose and any other directions about it. And it sounds good if you can be a bit more detailed. That really helps. And make sure that the patient is happy with that. And if they aren't, you know, offer something different. Safety netting and follow up. If you don't get those in within it was 10 minutes when I did RCA, but it's extended to 12 now. But if you don't get those in within the time, you lose a lot of points. So you need to make sure that you allow enough time for those.
That's a very comprehensive structure that you had. So this is very important in terms of having a framework in your mind so that you know where you're going. And so many registrars don't have that very clear in their mind, and it does make a big difference when you have that. And looking at how you've done it, you've written it down, and it's helpful to have it on paper as well. So as we did touch upon about the different ways of doing things, so each person will consult differently. So there's no one way that is the perfect way, and you can actually develop your own consultation model and borrow things from others, such as yourself. You have taken something from Neighbour. One of the things that's very important in terms of acknowledging patients' concern, and you did mention when we talked previously about the receipt. Would you like to tell us a little bit about that, Caroline?
Yes, so I really, really strongly recommend this book by Roger Neighbour entitled Consulting in a Nutshell. And this was something that made a massive difference to me. What I was finding before I read this book, and it was my friend Victoria that recommended this book to me, I used to find that I was trying to do like open questions and some empathy and trying to get the patient talking. But if the patient came with symptoms that were really distressing, sometimes no matter how I tried to ask questions to like clarify the diagnosis or move the conversation on, I would get a reply that was basically just repeating what they'd already said. And the time was ticking by, and it was quite panicky for me as a trainee, thinking, how am I ever going to crack this? How am I ever going to get this done in 10 minutes? But what Roger Neighbour talks about is it's not good enough to have a sort of neutral catch-all empathy type reply like, oh, that's been very difficult for you. That doesn't really work in that sort of situation. What you really need is what he calls a receipt. So say for instance, if the patient, this is one of the patients I had, was telling me it really hurts, they're very dramatic like that. So if I said, you know, oh, you know, this has been very difficult for you, then I would get, it really hurts, and you know, a repetition of that. Whereas if I say a receipt, which is, you're, you know, as you say, this is really hurting you, then they feel heard, and then you're able to then move it on. And he also talks about that you can turn a receipt. So you're kind of like highlighting with highlighter pen the thing that the patient said that was really important to them, that they need to know that you heard, kind of in their own words. But I quite like saying, as you say, or as you said. That seems like an easy way to do this giving a receipt thing. So if I said like, oh, as you say, this is really hurting you. So tell me, how is it affecting you in your day to day? What sort of things is it stopping you from doing? You see what I mean? So you've moved the conversation on to another bit of really important information. In this case, it's the impact, which comes under psychosocial.
So yeah, a very good point actually. The language that you use is important, and if you can mirror the patient's language, they actually feel heard and understood, and that's where you get really good connection and rapport when you're building rapport with your patient. So that's a very good point that you mentioned about the receipt from Neighbour that actually move the consultation forward for you. Tell us a little bit about how you were selecting your patients, because that's a big challenge for many registrars. They can't actually get patients who are suitable for the RCA. What were the things that you did, Caroline?
Well, when I was on the course with you, you very helpfully pointed out, and it was really very powerful how you explained it, that it's not just the registrar that's doing the exam, it's actually the whole practice. I thought, wow, actually that really gives me permission to ask for that help. Otherwise, you're just kind of silently hoping that cases will magically sort of come your way. And on the Bradford VTS website, they've got a sort of a letter that you can copy and paste and amend to give to the receptionist. So I used that letter because it was really good, and I actually sellotaped it to a box of chocolates, so that a box that was big enough to sort of last for a day or possibly two in reception, to make sure that people saw the letter. And I also sort of verbally sort of explained to them a little bit, that I'm taking this exam, and can you help me to get the right sort of cases. What you really do want, ideally, is whoever books the patients in is explaining to them that you're recording that day. If they say it in a quite a matter-of-fact way like that, you're in a training practice anyway, so they kind of are used to there being trainees there, if they're familiar with the practice. If they make it sound like it's perfectly natural, obviously not pushing people to be recorded, but making it sound like it's quite natural, then when you then send them your message on 14Fish, and again, it flows from that. Obviously, if they turn around to reception and say, well, I don't want to be recorded, then reception will probably be able to put you a little note to say, they don't want to be recorded, and they'll put that on your screen, on your diary. And obviously then, you'll totally respect that. But just knowing that reception are doing that is really helpful. Personally, I was duty doctor, as they call it, quite a bit. And that was really useful because I was often in the same room as the receptionists when they were fielding those calls, sort of care navigating. So they might lean over and say, what shall I do with this patient? They're describing this and that. And I would say, oh, put them on my list. Can you let them know I'm recording for my training today? So that, it was very fresh then that they would say that. I very much used the FourteenFish RCA package to watch all those webinars where they explain about what sort of cases are going to score you good marks. You've got to be really strategic. So on the one hand, there are these mandatory criteria, which obviously you've got to get those cases, available to submit. You can't actually submit if you don't have those mandatory criteria. And if you try and squeeze something in and pretend it meets the criteria, then you risk losing a lot of points, don't you? Because of this, that case could be disqualified, and then you've lost 18 marks, haven't you? Which could make all the difference.
It's very good that you talk about this criteria, which leads us to the case selection. How actually did you select the cases that you're going to submit, Caroline?
I think at first, when you're first taking on recordings, you're not going to be in such a position as to be very selective about what you're recording. At first, you're trying to get to grips with the technology, which in my case, I found that quite challenging, really, to use the recording, getting used to the software and everything. But probably, younger people are probably more of a whiz at technology than I am. But as you start getting, a few recordings, and obviously you need to listen back to them, you need to figure out where did you go wrong, why did you waste time, and so on. What I found I needed to do then was to start keeping a complete tally, not just using the RCA 14Fish recording page, to do this with, but actually I did it as a separate Word document. Some people might use a spreadsheet for it. What you really want to know, you need to keep a tab on what sort of cases you're getting, and you need to be marking them. Now, I personally used the Bradford VTS website's RCA marking sheet, and I found actually that that was pretty much accurate, what I thought I was going to score for each case, as far as I can make out, because you get your marks combined. You don't get your marks back per each case that you sent in, but it looks pretty much like I scored myself accurately using that tool. It was very, very helpful and very much tailored to the RCA, so I would recommend that. And then for each of your cases, well, this is how I did it anyway, on my tally sheet I've got what the case was about, does it meet any of the mandatory criteria, what is the clinical topic, what am I scoring myself on the three domains, the data gathering, clinical management, interpersonal skills, what's the total score, and then sort of some comment about, you know, was it any good or not, or, you know, pros and cons about that case as something that you may or may not submit. So obviously there are some of the criteria are mandatory. I know that the examination criteria, that's been dropped, hasn't it? But when I did it, that was one of them. Mandatory are things like a child, an older person, a sexual and reproductive health, a long-term condition, a mental health. So you want to make sure that you are getting all of those sorts of cases and keeping an eye on. So for instance, say you've got a sexual and reproductive health case, but you think you would only score a 5 on it. Well, you don't want to be submitting that unless you're really desperate, because actually you want to be scoring at least 6 out of 9 on everything that you send in. It's a bit like playing cards, if you like, isn't it? What's in your hand? Well, I've got a gynae case here. I'm only scoring 5 on it. It's better than nothing. It's one of the mandatory criteria. So if I don't get a better case and the deadline is looming, I'm going to have to hand it in anyway. But if I get something better, I'll delete it and I'll use the better one, if that makes sense. And I was sharing that tally with my clinical supervisor. You know, a couple of times a week I was sending her an email, so she knew that I was keeping a tally of cases. You can't expect your educational supervisor to listen to all of them. They might be able to listen to a few, and the key thing about that is you really want to get their feedback. Are you scoring yourself fairly accurately? That's important. As for what cases I actually submitted, when you see on the FourteenFish RCA package, in the webinars, they give some really helpful hints and tips. So they very clearly say things like dermatology, a very basic sort of 2-week wait, like a breast lump or something like that, where there's only sort of one likely clinical management and not much discussion. ENT, they say, please don't submit anything like earwax, you know, nothing simple. They tell you which ones to avoid. On the other hand, they also make a really helpful comment about what sort of cases are likely to score well, because they've got to have that right degree of complexity. If they're too simple, you're not going to have the opportunity to show what you can do. On the other hand, if you go for something too complex, then it's impossible to get it done in the 10 minutes. You won't get in the safety netting and the follow-up, so you'll lose a lot of marks, even though you might have showed really nice rapport or something. In the end, I actually used 4 cases which were gynae or obstetric type cases, and that is perfectly, it's allowed. It's not recommended, but it's actually allowed, or it was at the time when I submitted, because on the FourteenFish RCA package, they pointed out that those sorts of cases and mental health cases tend to score quite well. So I submitted 3 mental health cases. For my child, it was a youngster who had acne, and it was really affecting her self-esteem, and she was very self-conscious about it, and it was impacting her at school. That's important, because if it's not doing anything to affect them in a way that's specific to a child, then just the fact that they're young, they wouldn't meet a child criteria. And then a stress and migraine case, which is almost mental health, isn't it? A hip pain. a sore throat, which obviously is dodgy, but I sent that one in. My supervisor really liked the case, and so I sent that one in. Swelling of fingers, which that was obviously query rheumatoid arthritis. That could have been a really poor case, other than it was made a bit more complex because the patient was saying, I hope you're not going to tell me that this is rheumatoid arthritis, but so that's what made it interesting. And then a known hypothyroid case, where again there was a bit of negotiating with the patient. If it was just a plain, I've got hypothyroid, what's my latest blood results, please, thank you very much, that would have been awful, but there was a bit more discussion to it.
So there seems to be an angle to each of the case, a reason, like you want to showcase a set of skills for each case. I'd like to ask you, what was it about the sore throat case that your educational supervisor thought was interesting?
I wonder whether it was because it was a face-to-face consultation, and so I went with it, but actually there must have been a case that I scored less well on, and I suspect it was that one, because it probably was too simple. But I think because it was face-to-face, and bizarrely it was a patient that I had met in a different context. You know, she's a lovely lady and we had a really nice rapport, and I think that was what appealed to my supervisor. And it was very, very kind of the patient to, you know, to let me submit that for my RCA. You know, I'm glad to say that it sounds like she's ended up being quite well, so that's wonderful. But I think it probably just was a bit too simple, because in terms of the management plan, that's the difficulty, isn't it? So an ENT case, there often isn't very much negotiation about what to do about it. That was the only one that I did face-to-face. All the other ones were telephone, and I think that's a dilemma that trainees worry about. And it seems to me that actually I probably scored less well on that ENT face-to-face, and, you know, got good scores on the telephone conversations. And the wonderful thing about the telephone thing is, if you are having a little look in a book, obviously you can't be sticking your nose in the book and reading it wholeheartedly. You've got to already be familiar with what's on the page, but just glancing at a book and scribbling things on your crib sheet, it doesn't come across on the telephone. But if it was a video consult, it could look pretty clunky. So personally, I can't see what would be the advantage of doing a video consult at all, or it wouldn't have worked for me. Telephone consults were just fine.
In terms of what you were expecting and the score that you got, you said that it was quite accurate. Would you like to share your score with the audience, Caroline?
Overall, the score was 169. The pass mark was 143. So to get 143, you'd have to score about 6 or more, you know, roughly 6 out of 9 for everything. What I did, as I say, I used the Bradford VTS. I printed out the individual sheets, and for each, you know, listening back on my recordings, I suppose I'm being a bit old-fashioned, but I hand wrote on them, you know, ticked where I thought I was scoring, where I wasn't, and put the, you know, the numbers, and then I kept them all in a folder. That's just how I like to work, really. So I just could easily, you know, look back on them and think which ones were better, which ones were worse, because it's quite hard, isn't it, to, you know, to compare like one gynae case and another gynae case and which one's better or which one's worse. You could waste a lot of time unless you keep a good note of why you came to the conclusion that you did. So, you know, a few little annotations as well, saying why you thought you scored, and then if you can get a subset of those listened to by your educational supervisor, just to make sure that they think you're marking correctly.
What I find is useful is that when you're very organized, then you won't have to actually panic in the end, having to go through so many cases. And you're not actually, if you do it that way, then you won't be using that iterative cycle, which seems to me that you have been doing continuously through the process, that can help you to elevate your consultation as you go through the process.
Yeah, definitely. You want to been making sure that, well, I mean, I suppose it's my age really, isn't it? But I'm a little bit nervous of technology. So I had this fear that on the day there'd be something wrong with the website when I was trying to submit. So I actually submitted a day earlier. But as you say, with my tally sheet, if you like, of all the different cases, I was pretty sure about what I was going to submit. But, you know, even the day before, you might get a better case. And as long as you know the cases that you've got, then you can compare, well, is this new case better, and shall I swap it in for something? But I also found it was quite a good discipline to delete ones where you thought, no, that, actually that's either too simple, or there was a mistake in it, or I didn't explain that quite as I would have liked, or something like that. Just delete them, so that you don't end up in a muddle on the day that you're trying to submit and accidentally submit the wrong one, or make a decision last minute that you might regret later.
Talking about the score in terms of the domain, how was your score for each domain, Caroline?
So 59 out of 78 for data gathering, 50 out of 78 for clinical management, and 60 out of 78 for interpersonal skills. So I think that the data gathering and the interpersonal skills, they were pretty similar, 59 and 60. And then the clinical management, despite all the studying that I did, the clinical management, I got 50 out of 78. So that was quite a bit lower. So it was definitely worth, the study, and obviously room for more study, which, we keep doing, don't we? We're always keeping on trying to do better.
But yeah, I think this is a common weakness for many registrars. Clinical management is where most registrars do struggle to score high. What would you say that helped you to make sure that you had a robust clinical management?
Definitely. Well, one thing that I started doing early on, which was just my personal style really. So I quite like flashcards as something that I can look at when I get a quick opportunity. I find that's a way of sort of drilling information into myself. So I did it initially around red flags. And I think a lot of trainers report that they think that registrars are weak on red flags, just generally. Obviously not every registrar, but many are. So what I did for these flashcards was I would think up lots of different symptoms. I went on the Pennine VTS course, and they pointed out that it would be a good idea to have your your red flags and your clinical management as a bit of a revision that you created for yourself. But I'd started with the red flags. So any symptom that I could think of, like, I don't know, heavy periods or low mood or, tired all the time, I would make a flashcard of that symptom and then all the red flags associated with it, and try and cluster them into something that made sense, like what diagnosis they would point out. And that was an exercise that actually took me a long time to do and a lot of effort, but it was worth it. I had to look at a lot of different resources actually to find that. So these couple of CSA revision books, I wish I'd come across this earlier, but there's a nice textbook of general practice called Practical General Practice. That's good as well. But I ended up buying that later on. I hadn't realised about that in time. But I looked on, patient.info, CKS, lots of different resources like that to pull together these red flags. And then these CSA revision books, what I found with them was that they're quite useful because they structure as if to help you with the CSA, which obviously it doesn't exist anymore, but they give you some topics and the red flags, but it wasn't always 100% comprehensive, especially when it came to the clinical management, because in this RCA exam, you've got to say exactly what medication you're offering. It's no use saying, I'll give you an ACE inhibitor. That really doesn't wash. You've got to say the name and the dose, etc. So I was annotating those books as well. I was writing in those books those sorts of extra bits of information, so that when I was on the phone, either it was in my head, or I could very quickly just sort of open the book and glance at it and think, oh yeah, that's the right medication, just as a little aid memoir. But you know, other people might find that they remember things in a different way. But you know, for me, that was just useful to have things that I'd handwritten. I think that process of handwriting, that sort of embeds it a bit in your brain as well. Like you say, you've really got to make sure that you don't just gather information about their psychosocial or their ICE and then just leave it as if, oh, I've ticked that box and I can forget it. You've got to make sure that you show that you did listen to the patient. So sometimes they will drop you little hints, like, you know, they might sort of directly give you an answer when you say, you know, was there anything in particular you're hoping we might do about this today in the ICE bit. Sometimes they might say, oh, well, yeah, I thought you might give me some medication for it. So in that case, when you come to discussing the treatment, if you remember to say, oh, you know, like you said earlier, you'd be quite interested in some medication. I think that it would be a good idea. Did you have anything in particular in mind? Or another example might be things like contraceptive pill or HRT. It's worth asking the patient whether they had a particular brand in mind, because they might have had a conversation with a friend or family member and come across a particular one that they would be interested in. That's worth asking. But equally, you know, if they've said earlier on, I'm not the sort of person who likes taking tablets, then there's no use sort of saying, I suggest I prescribe you, because they will think, oh, you didn't listen to what I was saying before, you've forgotten it already. If you think from the ICE, they haven't really said one way or another what they might want, you can then sort of introduce that a little bit in the discussion about the clinical management by saying, well, some people quite like to have the medication, some people would rather wait and see a little bit, some people might want to do some self-help or be referred for some psychological talking therapies. I wonder where you know, what you might prefer. So rather than going into lots of detail about something straight away, you know, you're sort of trying to gauge what they prefer. And then you're always trying to think, leave myself enough time for the safety netting and the follow-up, otherwise I'll lose lots of points.
It's very important to actually integrate what the patient has said in the first part in your clinical management and involving the patient, making that decision with the patient rather than making that for them. So I think this is something that really stands out when it's done well, and taking into consideration the person, not just giving a generic plan to a patient who's coming with problem with leg. So before we wrap up, Caroline, I think it's very important that we look at the process of you actually passing this first attempt and the work that you've done. Certainly, I'm sure that it has actually helped you in terms of consulting for the career ahead in general practice. Looking back, what would you have done differently?
Well, I do wish I'd bought that Roger Neighbour book and also the Practical General Practice textbook earlier, because as I was mentioning before, the Roger Neighbour book, it's just so very good at answering lots of worries that I think I had as a trainee about how will I ever get to be more concise and more time efficient. It just doesn't even seem possible. And you know, his method of the patient's part, the doctor's part, the shared part, and the receipts and turning the receipts, those were all sort of, you know, really amazing. And it is a book that I will be rereading, I think, because it's got lots of wisdom in it. And then this book, this Practical General Practice, edited by Staten and Staten, or Staten and Staten, that is so very good, because I find you know, you do want some resources there just before you ring the patient sometimes, and that has got things that if you tried to Google tables and bits of information, you could be Googling for ages and not find what you were actually looking for. But that's got lots of really practical useful things in it, and it actually sort of explains, it's just pitched right for me really, so it explains conditions before you're in the patient. If there's a condition that I haven't felt very comfortable with or confident in, and I've got an idea from what's written on the screen as to what we might be talking about, I can have a quick dip in that book beforehand. Obviously your course was very, very helpful. The other things that have been so very helpful, having study groups has been really, really good. Peers have been very kind. And even though, we couldn't meet face to face, we've been having study groups on Zoom and things. So that's been really, really good. I'm a big fan really of books, so I find them very reassuring. I could even sort of pat them now and say, thank you books, but thank you to Dr. Erwin Quinn as well.
Thank you. So thanks a lot for sharing your insights, Caroline. I'm sure that our registrars will appreciate your honesty and sharing your process experience, what you've learned.
Do you want to take things to the next level and give yourself every chance to pass the RCA? I'm offering a limited one-to-one coaching service where I guide you every step of the way. If you don't want to risk failing the RCA, book for the RCA Blueprint coaching session today, where we can discuss how you can implement strategies, tactics and tools and receive personal feedback to help you pass the RCA. If you want to join the limited coaching program, click the link down in the description below. If you have any questions or any suggestions, please let me know down in the comment section. Take care everybody. Bye bye.